Good morning. My name is James Stanger, um, and I'd like to talk about clinic variability on this cool, rainy Australian winter's day. And it's based on a paper published recently by some authors from Turkey. Clinician-related variability is an independent determinant of IVF success. A retrospective cohort study of intracytoplasmic sperm injection cycles. Okay, so this is just a real quick paper. And they concluded right from the start. I always like to tell you where I'm going, but please don't stop and please watch the video to the end because it's always worthwhile. The conclusion of the author said was, our study showed that clinician-related factors independently shape IVF success. Clinical expertise, judgment, and surgical skills affect outcomes through the IVF cycle, not only at embryo transfer. Improving laboratory conditions alone is insufficient. Clinician training, performance standardization, and ongoing professional development are also essential. Thus, clinician performances should be integrated into quality assurance programs and further evaluated in prospective multi-center studies. So the materials in this cohort study are data of 3,000 women who underwent ICSI at the IVF Center at Kadoki Florence Nightingale Hospital in Istanbul, Turkey, or Turkiya, I apologize, between 2013 and 2020 were extracted and reviewed. Clinical pregnancy rates, not the live birth rates, clinical pregnancy rates were compared between clinicians. So this doesn't include miscarriages, interestingly enough. So the results. Clinical pregnancy rates differed significantly between clinicians ranging from 13% to 56%, highest limit 0.02, and the overall pregnancy rate was 29, but basically 30%, which is not a clinical pregnancy rate of 30%. It's okay. It's okay. In the multivariate analysis, even after adjusting for maternal age, maternal body mass, duration of infertility, and AMH levels, the clinician variable retained its significance as an independent predictor of p-value of 0.018, which is pretty strong. And here's the data. 22 clinicians. These are the average pregnancy rate, clinical pregnancy rate. And you can see there's a reasonable amount of variability. It's not consistent, but the question is, how is this variability within the normal range? Well, I don't know. The normal range would be devised by what's there. But you can see there are some clinics which have got a very high rate, and there are a couple of clinicians, 1, 2, 3, 4, 5, that are quite a poor rate, and a couple of which are marginal. So the clinical pregnancy rates vary considerably amongst clinicians, ranging from 13% to 50%. Okay, I already said that. If you look at the spread, the odds ratio, so you can see here there's one clinician there, another clinician there, which have a significantly lower clinical pregnancy rate to everybody else. And there are also 1, 2, 3, 4, 5 doctors who have a significantly better outcome compared to everybody else. The vast majority are fairly consistent. But I've recalculated the data based upon caseload, and we look at the pregnancy rate against the number of cycles. This data was in the paper, but not presented this way. And you see most of the variability is associated with doctors who are not experienced. So redrawing the data as pregnancy rate by the number of cycles suggests that most doctors perform few cycles are only just starting out. So there's really only 5 or 6 doctors with a fair amount of experience. But even 250 cycles isn't a lot. I would have thought most doctors would have been in the order of thousands. But the vast majority of doctors were only doing a small number of cycles. And that could be for their case management run, or they could just be studying out any experience. The paper didn't identify why they only had small number of cases. But often in a clinic, there are usually 3 or 4 doctors to do the vast bulk of the IVF system, but there's often 3 or 4 or 5 other doctors who are very busy obstetric practice and gynecological practices and just do a little bit of IVF for selected patients. So the author's comments. These findings extend previous research by demonstrating that clinician-related factors influence IVF outcomes across the entire treatment cycle, not just embryo transfer. So decisions regarding ovarian stimulation, gonadotrophin dosing, monitoring schedules, trigger timing directly affect the number and quality of the oocytes. Technical proficiency during oocyte retrieval shapes both oocyte yield and integrity, influencing subsequent fertilization and embryo development. Although embryo transfer remains essential and is often a part of many EQA quality assurance programs, KPIs, etc., although embryo transfer remains essential, the variability observed amongst clinicians likely reflects the cumulative effect of multiple clinical options rather than a single procedural step. These results highlight the clinician as a key determinant of IVF success alongside individuals and laboratory factors, and I think I agree with this. If you look at some of my other videos on KPIs, which I do for an Indian meeting, a lot of the work that happens in a clinic, which has important KPIs, are clinician-centric. While embryologist-related variables are well standardized, clinician variabilities have received limited attention, and they should. Incorporating clinic's performance into an IVF quality assurance systems as a measurable component may help address this gap, and several mechanisms contribute to this variability. Technical aspects such as follicle aspiration, minimizing trauma, and precise embryo deposition may affect implantation potential, but there's also clinical judgment in tailoring stimulation protocols. Determining the trigger timing and adjusting medications is also crucial. Beyond procedural skills, effective clinician individual communication, evidence-based practice, and coordination with embryology staff may enhance outcomes by improving compliance and workload. So my comment is, it seems to me that to be aware and to let clinicians be aware of their overall pregnancy rate is a good thing, and that, as the authors suggest, this could be part of a clinical KPI program, but this needs to be tempered with an understanding of what the data is actually saying. And you can very quickly have a doctor feeling out of place because his pregnancy rate's poor, because all doctors are inherently very competitive. It may well be that it's not a technical issue, but rather a management issue. In many clinics, each doctor performs their own egg collection and embryo transfers, and if so, the KPI may reflect their technical expertise, but it may also be that they don't work weekends or weekend roster, and that will also affect it. It will also reflect their preferences for some procedures, just as ICSI over IVF or PGT-A or day 5, day 3 transfers, and it may also reflect the types of clients that are attracted as a referral. So there's a lot more to it. It's just that you need to recognize that there are variabilities. And after 50 years of IVF and working with, I would say hundreds, but maybe tens of different doctors, they're all very different in how they work. So my final comment, oh, I've cut this person's head off. That's not very good, is it? I do apologize. Far better for the clinic to have a defined subgroup of clients for comparative purposes, e.g. a cumulative live birth rate for women on their first cycle, say under 38, and that will be a better way to standardize the clinician's performance as opposed to a clinic variability. And hardly anyone does this, but I think actually all clinics should have a subgroup of women under 35 on their first 1 to 2 cycles as a standard group for all comparisons before you do anything else. And of course, the next question is, should this data be available to clients? That's for a clinic to decide. Okay, I'll let stop here. I think it's a great little video. My name's James Danger, and I'm an embryologist with 50 years experience. These videos from my first tube channel, Fertility Tube channel, are my attempt to bridge the gap between information you may need for your fertility treatment and the most recent publications available to your staff. I'm not a medical person, and this information is not medical advice, but it may help you in knowing what questions to ask about your treatment with your doctor, and maybe to help in understanding the advice that you receive. If you like what I'm doing, support Fertilate's IVF Daily channel, and please press subscribe and tell others about whether you think these videos are worthwhile. Just like to acknowledge that these videos are paid for by FertAid, which is my other company that has an online EQA program for IVF in andrology and embryology. I'd like to thank you for your time if you got this far, which I hope you have. I know IVF is a personal journey that involves the action of many techniques and people, and it helps to understand all aspects of that journey. I hope this information may be of value. If you like what I'm providing, please tell other clients about the service and please subscribe. And I'll see you again on a future video. Thank you for your time.